Yeah, I think so. Yeah, so everybody please turn your mics off. Thank you.
Okay, so today I'm going to share with you some ideas, some new fields I think to explore, because I will not give you clues of how to use lung ultrasound functionally in intensive care, but just to open new areas of research and thinking. So the first thing is, I think it helped me a lot is to understand lung ultrasound based on the physiology and the development. And the other thing is when we ventilate, because I will do functional lung ultrasound on a patient who is ventilated, so that would be the main topic, how lung ultrasound can help us optimizing the monitoring of our patient on mechanical ventilation is to look at the changes of the lung across development. And if we look at the content of the lung at 20 weeks, is full of parenchymal cells and a small amount of epithelial cells, which are expressing TTF1. But with time, we can see that the parenchyma becomes less and less abundant and more epithelial cells, and that functions change. The amount of muscular elastic cells are changing. And all these morphogenesis, growth, and maturation changes will, of course, have an impact on the mechanical properties of these lungs. And the objective here is how can we constantly adapt our mechanical ventilation to these changes in the mechanical properties on a developing lung, which is very, very vulnerable. And if we come back on the specificity of the newborn lung, on the left side, we have the curve of the standing pressure in adults compared to newborn. Here we have the curve for the chest wall compliance for the adults, here for the newborn. Here is the compliance curve for the lung in adult and the compliant lungs in newborn. And surprisingly, what is the most important is, and the total here, the resulting compliance of lung to chest wall is here and here. And what is surprising is that the main difference, or the important difference between adult and newborn's respiratory system is the big difference in the chest wall compliance. So the main difference in the compliance of the respiratory system of the newborn is mainly related to the difference of compliance in the chest wall. And in this newborn, we know that the main properties of this respiratory system is the very high compliance and high resistance and low functional residual capacity. And we will have to ventilate these lungs with all these challenges, and the low functional residual capacity will make this lung very vulnerable to de-recruitment and atelectasis, and the high compliance and high resistance will make it more prone to overdistension. And finally, the safe window of ventilation remains extremely narrow here. And what are tools today to ensure that we're ventilating these babies within this safe window? Mechanical ventilation, of course, is life-saving, but it will add some stress to the ante-per and postnatal insults, leading to the development of chronic lung disease, which is an arrested lung development, change again the mechanical property of the lung and make it even more challenging, especially as this disease is very heterogeneous. So what are our current tools today to monitor this mechanical ventilation and maintaining it in the safe window? At the time of ET tube insertion, we're monitoring with chest X-ray, but it can take time to get this chest X-ray, and we have to irradiate the babies. In terms of how do we set our ventilators, we always start with some standard settings that we adjust secondarily on the PV curves, on the tidal volume, the Pmax, on the hemodynamic tolerance. But we know that in newborns, because of the ET tube size, length, and lots of spontaneous breathing, there is a poor accuracy of the PV curves, It's very difficult thus to define the opening and closing pressure. And when we see hemodynamic consequences, most of the time it's a bit late. Infant positioning, when we have an atelic, we can see it on the effect of positioning, for example, some de-recruitment of the lungs due to position of the baby. So we can see that with a chest X-ray showing atelectasis. But when we do a chest X-ray with atelectasis, how do we know if it's anterior or posterior? How it cannot guide us really how to position properly the baby. And finally, weaning, we know that there's no defined parameters to tell us how and when to wean the patient. There's no defined process. So we can really wonder if there is a potential role for lung ultrasound as an adjunctive tool. I don't think it can replace any of the other parameters monitoring we have just described, but is there a potential role for lung ultrasound? And why not for the hemodynamic consequence for a combined lung and heart ultrasound to optimize this ventilation in a safe window? So we know that to ventilate in this safe window, there are currently some lung protective strategy which are in preterm newborn to start CPAP shortly after birth, to minimize oxygen exposure, and to ventilate with a low tidal volume, and having a set the proper PEEP, optimal PEEP, to avoid all this de-recruitment and atelectasis. However, despite following this, would say, this handbook lung protective strategies to optimize the PEEP and avoid atelectasis, still more than 30% of patients experience overdistension, thus the need for a more individualized medicine. So I wanted you to have some game, but I'm not sure we have the time. This is, so we won't do it now, but this is the patient with the BPD at 3 weeks old, and he's currently ventilated at 5 ml per kilo with a PEEP of 5, and Professor Edwards kindly provided me these MRI images when you can see really well the corresponding MRI, and you see all the de-recruitment in the posterior areas here and the distended area anteriorly. And I think this is what we would aim to see with the lung ultrasound, to identify precisely where the consolidated areas are, where the distended area, and to guide our ventilation. So first, the first step of mechanically ventilating a patient is to optimize the ETT position. And sometimes it's easy, we get the X-ray straight away, but sometimes we don't. And we know that even 20-30 minutes on elective ETT position can be deleterious. So after looking at a few works and techniques to see the endotracheal tip position with the lung ultrasound, I think this one is the one I think I've tried and used the most over the last years, and I think is the easiest and the most consistent. So it was described initially in this prospective observational study, including 29 patients ranging from very small preterm to term patients. 13 operators were involved, and an ET tube was deemed to be deep if the tip of the distance between the tip of the ET tube and the upper border of the aortic arch was less than 1 centimeter, and I will explain why. On the chest X-ray, it was defined as deep if it was below T3, and they find a concordance between the lung ultrasound and the chest X-ray to be 95%. When they could not see it, the patient has actually a pneumothorax. So how did they define this distance? Is because when you have the drawing here with the main bronchus, the carina, and the aortic arch, and actually you can see the carina is at the lower border of the aortic arch. The aortic arch is roughly something like 0.5 centimeter to 1 centimeter. So they define that if you want to be in a safe zone from the carina, you need to be 1.1 centimeters above the upper border of the aortic arch, which is an easy landmark to find. So this is a picture, ideal picture I personally exceptionally see, but it's been published in the last point of care ultrasound for neonates article from Stewart's, and which is the American guidelines for point of care ultrasound. And you see, as you can see, you have the aortic arch here, and this is the tip of the ET tube. And they measure here this distance, which was 1 centimeter. And this total distance here will give you the distance with the carina. So optimal distance for across ages, the safe distance is 1 centimeter with an excellent concordance. And if you can't see it, it's because it's either too high or because of the pneumothorax. So here is one clinical case, a baby we had in the unit. It's a 24 weeks who on day one had surfactant in the delivery room 2 hours ago and went really well, had the lines inserted. After 1 hour, we just left the baby quiet in the incubator, but suddenly we were called by the nurses because he became a bit mottled. We did the gas, and he had a respiratory acidosis. And I don't know if someone wants to comment a bit. It's not a good image, but you can see the ET tube here. And you can see the aorta that actually you can't see well because it's covered by this image, which is some air. Actually, you can see we're moving the ET tube slightly, because when you do this ET tube positioning, it's difficult to know that what you see is really ET tube. Some people make confusion with the nasogastric tube. So to be sure that what you see is really ET tube, we ask the nurse to do small movement of the ET tube and confirm that this is the tip. And you can see here that the tip is totally covering the aortic arch. So we just pulled back the ET tube by 0.5 centimeters. So we did that a bit later. And we will check, you have here a better image of the aorta, the upper border, and we measure the distance with the ET tube, which is 1 centimeter. And the baby immediately improved, and we didn't need to do an X-ray just for that day. Of course, we can use the ultrasound to check esophageal intubation. Currently, we use the anti-idle CO2. I'm not using it personally because I think we have enough tool to confirm that the tube is in a good place. However, in ultrasound, what you would see is a double tracheal sign. Here you have the sign of a trachea with these white lines, and just below you have like an artifact. And if you look at a vertical artifact, which means air here, because you could see even some horizontal line. And if you move to the patient with the ET tube in the esophagus, you have the double trachea signs, meaning that you can see as if you have two tracheas with some A-line here. So that was about the ET tube position. When the baby had the ET tube in, we need to optimize the optimal PEEP level to optimize the gaseous change and the lung mechanics while preserving the hemodynamic stability. And the reference methods that were used in adults are the PV curve method and the CT scan, of course. On the PV curve, it allowed the clinician to assess if when you increase the PEEP, if the lung volume increase as well, so that the PEEP induced lung recruitment. So it's quite an invasive and difficult method to assess because it needs the patient to be totally sedated, paralyzed, disconnected to the ventilator the time you keep on a fixed PEEP. And specific software not to take too much time to analyze the data. So it's not a method we should use routinely, but has been used in adults to confirm if a PEEP was optimized. And in this study, I will show you two adult studies, and then we will move to neonates that showed you how to confirm that lung ultrasound used to titrate the PEEP would correlate with the gold standard method to assess lung recruitment, which was the PV curve method. So they confirmed the standard gold standard method, PV curve method with a lung ultrasound to assess the positive and expiratory pressure induced lung recruitment in patients with ARDS. So they included 30 patients with ARDS, and they look at change of the PEEP from 0 to 15, applied PV curve method and lung ultrasound. And what they've defined in previous studies is the lung aeration score, the one we're using, was not reflecting where the aeration changes. It was not a good method to assess re-aeration, and they used a new score that they named the re-aeration and de-aeration scores, meaning that when you change for a score 3 to, for example, score 2, you have +1. When you go for 2 aerations images below, for example, for score 3 to a score 1, it gives you a +3. And when you go from score 3 to score 0, totally aerated lungs, then you get a +5. And the de-aeration is the same with negative number. What they found is this lung re-aeration score correlated well with PEEP-induced lung recruitment of PV method, but still we could not diagnose overinflation. And on this method, they looked, thanks to the lung ultrasound, they looked at regional analysis of recruitment mechanism. And I think that's a very key message here is when we recruit with PEEP, what we are doing is, for example, if you look at this area, which I would score like 2, it's white lungs, B-line white lungs. You don't see any A-line. You move from this score 2 to this score maybe 0 or 1. When you go to white lung here, again, you go to score 1. And here you have consolidated area with score 3, but you stay at score 3. So the main effect of PEEP recruitment is actually to re-recruit, to improve the recruitment of poorly aerated lung regions, but not to open up a region that are already unaerated, this consolidation. So you may open up a bit this area, but as long as you have consolidation, it's very difficult to open them totally, and this area remain a bit consolidated. So that's a key message from ARDS in adults with PEEP recruitment. You mainly reopen poorly aerated lung region rather than opening de-aerated lung region, such as consolidation. The other gold standard we said in adults to check the open up or oxygen, the recruitment of the lungs using the expanding PEEP, increasing PEEP, was the CT scan. And the advantage of the CT scan, if you can look at a global but regional aeration score. In this study, they included 20 adults with ARDS, and they do CT, lung ultrasound, and for both, in this patient, they did a recruitment with PEEP. They first shown that the lung ultrasound score regionally was well correlated with the lung density on CT scan. So that was a prerequisite to be sure that when the lung looks consolidated on the lung ultrasound, it looks also very dense on the CT scan. But again, they found the same finding that actually regionally, you don't open up significantly this consolidated region. Here, even if you open up a bit and you decrease the size of the consolidation, your score remains the same. And the same here. Here you have a B profile, and with increase of the PEEP, you decrease the number of B lines, so you change the number from score 2 to score 1. So you rather open up de-aerated region. And of course, they show that there was a good correlation between what you observe on the CT tissue density and lung aeration score. So in practice, what does it mean? So does it mean that when we have a patient who is deteriorating or increase his ventilation and oxygenation needs on the ventilator, the first thing is to identify is it is a homogeneous pattern or a heterogeneous pattern. Because if you have an heterogeneous pattern and you increase the PEEP, you know you will not massively open the consolidated area and you increase the risk of overdistension. And this risk is much less, is really decreased in a context of homogeneous disease such as neonatal RDS. So the recommendation were first look at the anterior areas. I mean, I just do the echo the presentation of Daniel Lichtenstein 2 weeks ago. It's very important that when he says it's A prime profile, B profile, C profile, is always referring to the anterior area of the lungs. So these areas are extremely important to investigate because it is where you would see the B-line in interstitial syndrome, when you will see the consolidation from pneumonia. They come first in anterior areas. So all these anterior areas are really critical. If you have a patient with respiratory deterioration and only a line in the anterior zone, you probably have focal loss of aeration in the back, heterogeneous lung, and you have a high risk of overdistension. So your increase of PEEP must be very slow and limited. Whereas in the anterior areas, you have a diffuse B-line profile. You know that when you will increase your PEEP, you have room to open up these anterior areas with a decreased risk of overdistension, and you can probably increase much higher your level of PEEP. Of course, in neonates, we don't go to this level of PEEP, but it's just to see the dynamic and how we approach the PEEP recruitment depending on the underlying lung pathology. So as a summary, check the anterior chest for homogeneous or focal loss of aeration. We have to titrate the PEEP accordingly until disappearance of B-lines in anterior zones. And we need to avoid total disappearance of B-lines in lateral and posterior zones, because in that case, you probably will have overdistension in the anterior area. So what's been published in neonates? Only 2 studies, well, 2 teams, 3 studies in neonates. It's really a developing field, and I think we really have to work and probably do similar studies as from adults in neonates, except we don't have a gold standard. But 2 studies evaluated the efficacy of the lung ultrasound in detecting the opening and closing lung pressures, always again to find this safe window of ventilation. And this study made the correlation with tracheal interleukin 6 in a randomized control trial. So they allocated 44 neonates with RDS to 2 groups, one with lung ultrasound guided recruitment maneuvers, and the other one, it was not guided by lung ultrasound, but oxygenation and usual practice. And they measured the tracheal interleukin 6 before the recruitment maneuver and on day 3. So what they did is they put the probe on the most dependent regions and have the stepwise increment is both PIP and PEEP to maintain the driving pressure. And they kept the probe on the dependent region and continued to increase PEEP and PEEP until the consolidation moved to a well-aerated zone. The same on the other side, and they usually find, and then they define the closing pressure at 2 centimeters of water above the closing pressure. What they found is a significant decrease in oxygen requirement duration, 6 versus 13 days, decrease in invasive ventilation days, non-invasive ventilation days, and NICU stay, and a positive correlation between lung ultrasound re-aeration score, duration of oxygen exposure, and duration of invasive ventilation and NICU stay. I think the interpretation of interleukin 6 is a bit difficult. And this is the second publication in neonates from an Italian group led by Dr. Piero. And they say, okay, in adults, we could see that they cannot open up totally this consolidation. So how can we predict that a consolidation can be opened up with lung recruitment? And they define something they call a S pattern for sunray pattern. This is how it looks like. This is the sunray pattern. It means that in the border, at the border of a consolidation, you have this area with white lung. You see this B line and white lung. And this would be the sign that if that appears while you're increasing the PEEP, it means that this lungs is recruitable. So for each, they've shown that in patients who did not have the S pattern, they would never manage to open up the consolidation. Whereas if they display this S pattern during recruitment, they could move to a totally consolidated lungs to the B pattern, which they would define at the opening PEEP. And so when they found the opening PEEP leading to the B pattern, they then very slowly decrease the PEEP one by one until the S pattern appears again. And they would define their closing PEEP as the stage just before, so one step before. So this was, yes, to show there were 4 patients, and this was to show here the sunrise pattern. The same team, led again by Dr. Piero, went a bit further, and they compared PEEP-induced lung recruitment based on oxygenation and lung ultrasound. So they had 2 groups, 13 patients, and some patients had both oxygenation, recruitment based on oxygenation, and so the same patient could have lung recruitment based sometime on lung ultrasound, sometime on oxygenation. So there were 28 lung recruitment maneuvers in total among 13 patients, and there was 14 lung recruitment maneuver done with lung ultrasound and 14 done based on oxygenation. You can see the characteristic of the patient, and they were at the mean of 14 days of life, and the primary outcome was to assess if there was a difference in the PEEP-induced lung recruitment between the 2 methods on the delta SpO2 over FiO2. So they applied exactly the same protocol as before. They start from the C pattern. The only thing which I was very happy about is in their new protocol is they start with a lung ultrasound guided position. It means if they identify that the consolidation was in the back, then they would first position the patient and put him prone. As you remember, the first study, they left the patient in the supine and they were scanning the dependent area. Here, they try to position the patient so the more under-recruited lung would put on the top, to moving the dependent area to optimize the lung recruitment and avoid over distension. So they started with the C pattern, optimize the patient position, and as soon as they see the S pattern, and most of the time it comes quite early after maybe a 2 or 3 increase of PEEP, then they continue to open until they find the opening pressure corresponding to the B pattern, and then they come down slowly, and for the same methodology they would define the closing pressure. And what they found, so a mean of 14 days of life, of course there was more change in position in the lung ultrasound group, because 9 patients had to be changed position before lung recruitment maneuver, instead of 1 only in the oxygenation group. And we understand why, because there's no way clinically to know where the lung is consolidated. And one among all these results, it's interesting to see that the primary outcome, which was SF ratios, SpO2 over FiO2, was the improvement was significantly better for the lung ultrasound group. So there was probably a better outcome. And then I retrospectively look at the patient I used to scan, because I did exactly the same actually previously when the patient was very unwell. The nurse called me, well, this patient is increasing the need of oxygen, the gas is not good, I've checked everything clinically. When you find this big consolidation in chronic lung disease baby, you just want to open up. So we turn the patient prone here to put this consolidated area on the top, and we started by very low increment to increase the map. And you can see, you see this opening like a flower here, this opening of the consolidation. And this area of white line behind that was actually, I didn't know, but that was a sunray pattern. So to summarize, in adults, we have a good correlation between the lung ultrasound score, lung ultrasound, and the tissue density on CT scan. The global lung aeration score correlates with PP-induced lung volume recruitment of PV curve, but mainly by improving aeration of poorly aerated areas, but not by opening non-aerated areas. And the change in lung ultrasound score does not correlate well with the PEEP-induced lung volume recruitment of CT scan. And actually, what is more interesting probably is to look at the regional lung aeration score. In neonates, we know that lung ultrasound-guided PEEP recruitment is feasible, but we have lack of gold standard, lack of recruitment markers. So as usual, I think we have to deal with the multi-parameter score, mainly based on clinical markers. Probably looking at the Pmax is really amazing to see that when we're recruiting with a lung ultrasound, you can see the mean airway pressure and the Pmax coming down if you ventilate with volume ventilation, improving the CO2 clearance. And it could potentially, by defining the opening and the closing pressure, it could potentially ensure that a mechanical ventilation occurs in an open and safe zone by identifying opening and closing pressure. And I think looking at markers such as tracheal interleukin 6, I think is a good way to have a objective parameter. So these were the effects of PEEP-induced lung recruitment, and the other important thing that we shortly discussed before were the effect of prone positioning. So I will show you first this study in adults and then move to a similar study in neonates. And I think this study in neonates were probably inspired by this study. That's why I show them both to you. So this first study was done in 51 adults with moderate to severe ARDS, and they were initially included before 36 hours of starting mechanical ventilation. And the patient was initially supine, then was put prone. He had the first ultrasound within the first hour of being put before putting prone, 1 hour after being put prone. This is lung ultrasound number 2. Then they left the patient on prone for 16 hours. They repeat lung ultrasound 1 hour before putting back on supine position, and repeat the lung ultrasound 1 hour after the supine position. And here it's the data showing two categories of patients. The green, which are responder to the prone positioning in terms of oxygenation, the one who responded well to, in terms of oxygenation marker, to the prone positioning. And the blue are the one who did not respond well to the prone positioning. And they look, thanks to lung ultrasound, area by area, and here it was a global result. So between the scan 1 and 2, when you put the patient prone, of course, the anterior area, for example, will get a bit less well aerated, whereas the posterior area suddenly are better aerated. But if you look, then you have some changes that are happening. When you leave the patient for 16 hours, you don't see many changes in aeration score, whether you are good or bad responder. And when you move back to supine, of course, you have the anterior area will get a bit less aerated, and the posterior less well aerated, and the anterior area that gets a bit more aerated. And this is here the global score. At the end of all the maneuvers, you don't have really big changes in the lung aeration score, even if you respond well or not well in terms of oxygenation. So what they conclude in this study is that the lung ultrasound score will not change really and cannot predict well the oxygenation response to prone positioning. And the answers, there are two answers. The first is that when you put a patient from supine to prone, of course, you open the posterior areas, but actually you're collapsing slowly the anterior area. So not sure you gain a lot. And the other thing that lung ultrasound, and that's a bit my mantra, is lung ultrasound explores only airways and parenchymal part. It does not explore what is a more vascular part. So maybe there's a vascular part and the VQ mismatch that is not described well by the lung ultrasound. So, and I hope this study made a lot of noise. Sorry, I haven't been able to report it fully here. But in neonates, there was this study published recently by the Italian and French team led by Dania De Luca in December, when they looked at the effect of 6-hour pronation. So that's not the 16 hours in adults. In 3 kinds of neonatal population, which were recovering RDS baby or acute for ARDS or evolving BPD. And they looked at the effect on oxygenation and lung ultrasound score of prone positioning for 6 hours. So the design of the study was either the baby was already prone and then they kept the baby prone for 6 hours and did a lung ultrasound before and after. Then they put they turned the baby, had a washout period of 30 minutes, and then did the first ultrasound on the back position and then after 6 hours. Or if the baby was back initially, they turned the baby. So the babies could be initially supine or prone, but they have 6 hours in each position. So what they found is, sorry, because I really did that last minute, but for RDS baby recovering, if you look at the lung ultrasound score, where the baby started prone, you can see a decrease on the lung ultrasound score initially, where it was increasing when you started supine. But if you, so yes, there was changes and improvement in the lung aeration score, but now I'm a bit more skeptical, because if you look at the end, you don't leave the baby prone forever. At the time, you need to keep bringing them supines, and the benefit at the end, I'm not sure is obvious here. So yes, you can see some benefit after 6 hours, but this effect is probably not persistent for longer time. And that's why I show you the adult studies, because the adult study left the patient in the prone position for 16 hours. So you can see some short effect here after 6 hours, but how would it be if you had left the patient for more than 6 hours? I'm not sure you still had the same benefit. Here is for the ERDS, neonatal ERDS patient. So the same, you can see initially some benefit in terms of lung ultrasound score, but then it's increasing again when you put the patient supine. And for BPD patient, the same, you have some improvement, and then you have an increase in the lung ultrasound score. So yes, you have a benefit from prone positioning, but just after the prone positioning, and it's not persisting really. And this is some image I had from my, I think the image in the article are a bit dark. So I took these images from patients we had in the unit at St. Thomas and BPD. And you very often see in the back this very consolidated area. And just by turning the patient for 1 hour, actually it does that job. You just open up everything. So yes, they are improving clinically. You improve oxygenation. I think it's something well known. What we know as well, yes, we are opening this region, but actually the anterior region are probably more consolidated. And I don't think this explains the benefit in oxygenation. I think it's probably the vascular part as well that could explain all of these. So what is the we all using prone positioning, but the lung ultrasound in this context will allow you to have a spatial detection of consolidation, position your baby optimally to move the dependent region consolidated, move them to non-dependent region, allows optimization before PP-induced lung recruitment to optimize the pressure direction, and have a real-time morphological monitoring of the reopening of these lungs by clinical case. And I will just finish with this short word reminding us that lung is not only airways, and I think this is a limitation of lung ultrasound is it's not only a way we have as well to assess the circulation and hemodynamic effect. And we know that there is this heart-lung interaction of mechanical ventilation. And yes, lung ultrasound can help because we know some conditions such as PPHN, pulmonary hypertension later on, pneumothorax or mechanical ventilation not properly set up. So from the lung, this lung pathology would have some consequence on the heart, such as high PVR and right ventricular dysfunction, such as displayed on these images. On the opposite, the heart, some loss of heart pathology, the one which leads to pulmonary overflow, post-capillary pulmonary hypertension, oligemia. This heart pathology will have some consequence on the lung that you can see here. For example, you would see this interstitial, this lung edema. And I finished to illustrate this example, a clinical case we had in the unit. It was a 24 weeks on day 3. He was on HFO map 11 for severe RDS. He was found to have a significant over-distension of the chest X-ray. So during the day, the map was decreased to 10. And during the night, he had a hemodynamic deterioration. I checked the lungs and they were thin pleural line, some B line, but absolutely normal. A line, which for me, when you see them too well on HFO, for me, it's a sign it's slightly over distended. But most importantly, we had a very decreased significant flow in the main pulmonary artery, a bidirectional flow through the PFO, and a mean velocity in the ascending aorta, which was extremely low. So the reduced pulmonary and systemic flow. And sorry, I don't have the image, but we could see, and the right ventricle was not dilated. And the reason is, I'm sorry, don't get the image, the right atrium was totally compressed and shifted by the high mean airway pressure on the ventilator. It was really exceptional to see the compression of the right atrium by the high pressure. So just guided by this mix of lung and heart ultrasound, we decreased the map and switch him to conventional ventilation. And my mistake, I didn't check the ET tube when I did all of this, but this ET tube was a bit low. But you could see that after all this maneuver, the lung recruitment was better. Actually, the over-distension, was much better. So I think we should use lung and heart together to allow individualized and timely management of the ventilation for preterm babies. I think you know all that. So in terms of refractory hypoxemia, it means right to left shunt. I would look first for intrapulmonary shunt by looking at the lung ultrasound anterior and lateral zone to see if there is any lung edema or lung pathology, and to check if there is any consequence on the heart on a 4-chamber view to see if there's any sign of pulmonary hypertension. If I don't have any intrapulmonary shunt, that I will move to look for extrapulmonary shunt, looking at the intracardiac shunt with the PFO, looking at the PFO right to left shunt in like right obstruction, or if I have pulmonary extracardiac shunt through the duct and looking for other pathologies. So I think it's difficult to deal with patients in this condition without both lung parenchyma and heart. So I think lung ultrasound, personally, I think it's extremely useful for mechanical ventilation optimization, helping us to ventilate in a safe open zone. Lung ultrasound and weaning is still being explored. There was 1 or 2 studies looking at the left ventricular eccentricity index, but it was not really conclusive. Again, lung ECG and blood, and that's probably the limitation of lung ultrasound that we could probably improve by using functional echo. And that's bring us to a holistic and physiological approach, which is, of course, my favorite one, even if we still have a lot to show, to work on. And of course, it means that we have to be even better clinician, knowing the individual pathology, physiology, and hemodynamic challenges for each situation. Thank you very much. Do you have any question?
Hi, Virginie. Can I ask a question?
Ahmad, I don't know.
You can hear me, right?
Yes, I can.
So, thank you very much. This was a fantastic talk indeed. Again, the kind of stuff I'm going to listen to a couple of times later on as well. So, this patient you were talking about, the last one where where the evil was over distension. Mm-hmm. So I had a similar sort of patient. As far as I understand, the lung scan, it doesn't really help you objectify the extended lungs, distension of lungs. You still have to fall back to the X-ray to be sure. But yes, you can actually see air everywhere. And that's what I felt was the reason for almost exactly a similar situation of your patient, except that mine was a full-term baby, almost 3.5 kgs. So my question is, can you quantify, is there an objective way of saying that the lungs are over-distended purely based on the lung scan?
Currently, no, but I know many teams are working on that. For example, they are looking at the course of the pleura sliding. When you over-distended, you could see that the movement of the pleura, the expansion of the pleura sliding, it has less amplitude. So some of them are trying to following points of the pleura line to see the amplitude of sliding. So that's one area of research. I know some teams are doing that. The other one, I think that's a work to do. I can't currently, but it's really something consistent is to look at some, for example, when do we really need to look for over-distension is mainly on HFOV. We have to do regular X-ray, and I still do them, to look for over-distension of HFO. And what I found is actually a normal expansion, but it's purely empirical. That's normal distension on the baby on HFOV is to have a B profile and not A line. When you see your A lines too well, it's most of the time we are over distended. So I think what we could work on is to look at criteria on how do lung ultrasound look like when you have over distension on an X-ray, and to define criteria, maybe on terms of lung scoring. Maybe these lungs, when they're not over distended, it should score 1 or 2 and not 0. You see what I mean? So I think there is a work to do correlating lung ultrasound and X-ray of babies who are distended and not distended on HFOV, because looking at lots of them, this is what I came with. But you're right, we still have to do X-ray currently to assess over distension. On the case I showed is because it was so marked that we have the hemodynamic effect, but it was too late. We shouldn't have waited until that time.
Thank you, Virginie. So that one interesting thing which I have been using in a way to say that this is really over distended is the fact that you get a very pronounced tricuspid regurg. It is PPHN. You're treating the baby for PPHN, and your right ventricle is not that big looking, and the right atrium is kind of normalish in size. Yeah. So that's something I thought was one way of saying, and interestingly, you mentioned this in your patient.
That's exactly the same case, yeah. Your right ventricle is not dilated. Your right atrium is actually a bit really squashed. I really had a big squash on the right atrium, and you have sign of pulmonary hypertension. So yes, that's very, I think we need to explore that. But don't you think it's a bit late when you have already this heart effect on over distension?
It is. I mean, if let's say right from the beginning, I had that baby, you could have said, okay, why didn't you look into this earlier? But this is like you and me, we get, somebody asks you to come and scan, right? So when you go in, it's already been managed for a couple of hours situation. So this full-term guy, we started reducing the map, and then eventually we changed this baby to conventional. It was almost a very similar patient, except that yours was a very premature one in mine. And yes, the right ventricle, I was discussing some patients with a cardiologist who usually see patients like 10 days. For them, 10 days is very early. So he looked at a 3 hours old baby's echo and he said, the first thing is look at the right heart. It's so huge. I said, that's fine. I can tell you, I can show you on this machine dozens of echoes where a 3-hour-old baby will have a very prominent right ventricle, tricuspid regurg, and big right atrium. That's the most usual thing I see. So when this sort of situation, you see a right ventricle not big, and the right atrium as well with a massive tricuspid regurg, that
absolutely.
stands out.
Yeah,
that stands out. And the baby on HFOB, there is only one answer to this.
Yeah, of course. Yeah, that's very interesting. You should explore that. Other question?
I can't see anybody on the chat either.
There are a couple of hands up, so I think, Mahmoud, yeah.
Yeah, hi, thanks Vergini for that. That's awesome talk, actually, really good. Just a couple of questions. We actually had similar case to yours. The baby was on high frequency and then was just doing routine echo, and I did lung ultrasound, and I saw very clear A lines on that 24-weeker baby, which just didn't make sense. And on MO, there was like evolving barcode sign, if you like, or stratosphere sign. So at that point, we requested chest X-ray and we reduced the map, and we could see start to evolve like air leak pattern. So we actually predicted that earlier because X-ray was meant to be few hours down the line, but we just did it early because of this lung ultrasound pattern. So that saved the baby to, to have a significant pneumothorax, and we started weaning. But I'm actually quite interested in the study you mentioned. The two studies that was done for neonatal population for lung recruitment. One of them looked at interleukin-6, and they found that was reduced in the lung ultrasound arm. I think that's really interesting because that means that we can actually reduce BPD by lung ultrasound maneuvers.
Yeah. Sorry.
And how much, like what kind of the highest peak they've used in this study, and what was the mean?
But for the result of the interleukin-6, I didn't put it because based on the result in the table, it was not significant, but the authors concluded it was. But I think they didn't have enough patients, and I think I disagree with the interpretation. That's why I didn't put the result, but it's debatable, but I love the methodology. I think this is a good idea to do that, but it was not significant, to be honest. But we need to think, is it the right time, 3 hours after the recruitment maneuver? Maybe it's too early. Maybe we should do that later, because I don't know the time, how long it takes for 3 days, sorry. How long does it take for the interleukin-6 to be the half-life? How long should we detect to be detectable? I think it needs a bit more studies on that. What is the optimal time to dose the interleukin-6?
Yeah, absolutely. Thanks, Vergini.
Vergini, one thing I was very useful today. Well, your whole talk was fantastic, but another thing that I found very useful is that air leak, over distension, and a little bit of air leak that doesn't need drained, but there is leak around, that obscures the ET position. It becomes, and I felt this was the case, but thank you very much for teaching this today. If there is air leak over distension, it really becomes tricky to comment on the ET position confidently on scan.
Yeah, thanks.
Ahmed, I think Sojus and Anna had their hands up at some point. I don't know if they still have questions or that's been discussed already.
Mahmoud, there is an echo coming up from your mic, I think.
It's okay. I had my hand up just to thank Virginie for her talk more than anything else, and especially because she showed us what lung ultrasound can do outside the assessment of the structure of the lungs. You know, what can you understand from that ultrasound that's going to make an impact on the patient, not just today, but also in the future. And I share with her some perplexity about the proning article, because I think our nurses have taught us years ago how good it is to prone the patient. Equally, we don't keep the patient in a prone position forever. We keep changing the position. So how that has an impact is going to be a bit more difficult to assess. And I don't think there's any unit that doesn't prone the patients. I think we all constantly change the position of the patients. But I was just thinking we definitely need to think about how we can develop a sort of score or assessment that can be easy to be achieved, and that could combine an assessment of the lung function and the heart function. And as we were mentioning, Virgin, this is something that some groups have been working on, but more and more I hear about lung ultrasound score and the correlation with the ratio between saturation and FiO2. That's very much lung still. So definitely we need to look outside the lungs and go back to combining the lung ultrasound with the functional echo. And it's good to see that many of us are already thinking about it and seeing cases where that combination, at least in our brain, was working, is how to translate that into something that can be replicated in other patients, in other units, and become a useful tool for all of us. Definitely something to work on.
Totally agree, Anna. Thanks for this comment. It's really, really useful. And I think Jean approves totally.
The other comments I can make is that I do use lung ultrasound when to re-recruit lungs, but I have to say I should be using a lung ultrasound every time I put a patient on a ventilator, because we all start from the idea that we know where to start from and what kind of PEEP or what kind of tidal volume or pressure, if you're on pressure ventilation, we use. And not only, but I often just use the lung ultrasound when things are not going the way that I like things to go. But actually, maybe we should be using lung ultrasound every time we start a patient on a ventilator and see where we are at, and if you're actually starting with the correct settings, instead of waiting for the overdistension to come in. And then I'm thinking, oh, there's something strange. Let me have a look.
Yeah, and I think it's something very important you are saying now, I forgot totally to mention, is when we look at the lungs of this patient on the ventilator, even if they are stable, you constantly find consolidation in the back, like chronic lung disease. And when you think you are doing lung protective strategy, ventilating them at 5 ml per kilo, if you have half of the lung volume that are totally consolidated, you can see obviously that you are ventilated, maybe your baby is at 10 ml per kilo, which is not what you wanted first. So I think keep monitoring regularly the aeration of this lung, for me, is crucial to be sure that what you think you are delivering to the baby is effectively what the baby gets. It's not going to be very accurate, it's semi-quantitative, but if you have half of your volume consolidated, you may first optimize the PEEP, open the lungs before and secondarily adjust your tidal volume, rather than thinking that I put my PEEP of 6 like any other babies and I put the tidal volume at 5. This is what we think we give, but it is not what the baby is receiving. So thank you for this comment. I think we should really do it more routinely on babies before they get unwell.
Sujit, I saw your hands up before, but I'm sorry if I stepped in. I don't know if you still have a question.
I think we're done.
Yeah, I think Sajid walked away or something with his hand up. Okay, if there are no further questions.
Okay.
Thank you very much, Vergini.
Okay.
That was just great. Thank you. Thank you very much.
Thank you very much, everyone.
Thank you, Vi. See you soon.
Thank you, Ahmad. Thanks. Thank you, Anna. Bye.
Bye-bye.
Thank you.